I'm Gordon Christie. I'm a consultant chest physician in Aberdeen, and I'm involved in provision of hospital care to people with chronic lung disease. COPD is a chronic lung disease caused primarily by smoking. It's caused by inflammation in the lungs, which results from breathing in the products of combustion, soot particles, hot gas, tar, all these other materials that are in cigarettes. If you look historically, then exposure to industrial pollution in heavy industry also caused some degree of COPD, but in the UK now, COPD is overwhelmingly a disease of smokers. Only around 50 to 60% of people who smoke get COPD. There's undoubtedly some genetic susceptibility to the particular kind of inflammation that causes COPD, although we don't understand what it is that gives you that susceptibility. Certainly if you've got a family history of the disease, you would be more concerned that you may develop more severe disease. In terms of what's actually happening in your lungs, essentially two things are happening. There's inflammation of the airways in your lungs, which results in cough and spit primarily, and there's inflammation of the lung substance themselves, which is where gas transfer in the lungs takes place. The lungs are there to get oxygen into your body and carbon dioxide, the waste gas we all make naturally just as a result of being alive, out. And what happens to the lungs themselves, inflammation results in a reduced ability to exchange gas, and that means that you get breathless. COPD used to be called chronic bronchitis, which is the cough and spit, and emphysema, which is the loss of ability to exchange gas. The initial symptoms of COPD are often quite mild and quite subtle. There are basically two groups of symptoms. One is that you will become gradually more breathless when you're doing things, initially only on fairly significant exertion. And in truth, most people don't really notice that because they adapt. They do a bit less. The other thing that may be a pointer to COPD developing is frequent chest infections, or what people often describe as episodes of winter bronchitis or more severe colds, particularly during the winter. So if you're getting more chest infections, cough, spit, feeling a bit off colour, and more frequently, often several times a year, then you might become suspicious that there's something underlying that. And in smokers, that often proves to be COPD. The most important drug treatments for COPD are mainly to do two things. They're to try and open your airways a bit, so to improve your lung function a little and enable you to do more. And also, particularly as the disease becomes more severe, treatment is very much directed at reducing the number of flare-ups that you have. The majority of drugs for COPD are given as inhalers, which is a relatively inconvenient way to take medication. There are broadly two different groups or two different timings of inhaler. There are those that work quickly, which you can use to relieve symptoms, and these have some benefit in COPD, but importantly, the drugs that we're giving to improve your lung function slightly, and particularly the drugs we're giving to reduce the frequency of flare-ups or exacerbations, have to be taken regularly. They don't work if you only take them when problems are starting to develop. It's almost inevitable that at some stage in your disease you will develop a flare-up or exacerbation of your condition, and in that circumstances the drugs we use change. We will often give you a short course of antibiotics or a short course of oral steroid tablets in order to get things back under control, but at the same time you should continue your regular preventive medication. In some people with more severe disease, we may well end up using drugs that you may have heard of in the context of other conditions to control some of the distressing symptoms such as breathlessness and anxiety, and your GP can advise you about how best to use those to try and maintain your quality of life. Sometimes with more severe flare-ups of your condition, yes, you will need to go into hospital. The initial assessment will be done by primary care, by either your own GP or the out-of-hours doctor, and the things that will make them more likely to send you into hospital are situations where your oxygen levels are low or you're clearly really very unwell. If you come into hospital, we will make some initial assessment of you. That will often be in the initial assessment unit, and then if you are significantly unwell, you will come to the respiratory ward. When you're there, we will continue the treatment you're already on at home. The mainstay of treatment for acute exacerbations, flare-ups, is antibiotics and steroid. We also have access to the use of nebulized drugs, which are really very similar to the drugs you use in inhalers, but we can just give you them in rather bigger doses, and they're probably rather easier to take when you're ill by means of a nebulizer. Another thing that you may well have when you're in hospital is oxygen. Oxygen is very useful in COPD, but its use has to be monitored very carefully, and that's something we're well equipped to do in hospital. Rarely, if your breathing is very compromised, we may be able to give you some help using some form of ventilator, usually a tight-fitting face mask, something called non-invasive ventilation. Occasionally too, we may use intravenous fluids, and you shouldn't forget the fact that a key part of what we do in hospital is we provide very good nursing care, and that's a hugely important part of what my nursing colleagues do. Generally, you can expect to be in hospital for somewhere between 3 and 4 days. A lot will depend on how ill you are, and in truth, quite often it depends on how much care and support you have at home, because the availability of care and support as you're getting better, as you get into that sort of rehabilitation phase of your illness, is very important in determining how long you need to stay in hospital. There's a great deal you can do to help yourself if you have COPD. First and most important is stop smoking. That's not an easy thing to do, and there's a lot of help available for you to stop smoking. Remember also that a lot of people stop and start repeatedly, so don't worry about relapsing into smoking. Often it happens at times of stress. Just keep trying to stop. And you may find you have to do this 8, 10, 12 times before you finally stop, but persevere. One of the important things you need to realize about stopping smoking is that it doesn't restore any of the lung function that you've already lost. You can think of it in many ways as being getting off the down escalator onto the level. You aren't going up, but importantly, you're not going down anymore. There are some other very important things that you can do to help yourself. One is to remain physically active. So do as much as you can. Breathlessness is not dangerous. It may be unpleasant, but breathlessness is not dangerous. You won't hurt yourself or injure yourself by pushing on and trying to do something so that you're breathing a little bit harder than you normally do, pecking a bit, for about 15-20 minutes a day. A very important part of what we can offer you is pulmonary rehabilitation. This is a form of structured exercise class designed for people who have underlying lung disease, and it's run by the physiotherapy teams in the community all over Grampian. It is very important in terms of giving you the confidence to exercise and also teaching you some specific skills and exercises. And built into it as well is quite a lot of disease education and also the chance to meet other people in the same situation, because we know that having COPD and being breathless can be a bit isolating. Another very important aspect of helping yourself is to think through what might happen if you become unwell, if you have one of these flare-ups or exacerbations that we've talked about. We have an increasingly structured process called anticipatory care planning, where you can work through how you might cope with this with your family and with the help of your GP and the practice team and the out-of-hours team in the community. Obviously, if you need to come into hospital, we are open all hours and there, but if we can manage things in the community, then that's good. And it is definitely something we would want you and your family to do, is to think about and plan how you might cope with an episode, usually of infection, that causes a flare-up or exacerbation in your symptoms.